So if we look at our clinical practice, so with heart failure with reduced EF, I will say the main concern comes to us in the form of hypotension. And as I have discussed previously, it is less than 10% in my clinical practice that I have to remove ARNI as a molecule with those titrations or decrease in diuretics which we are, and with volume depletion, we are mostly able to give our patients ARNI in heart failure with reduced EF. Heart failure with preserved EF, because there are other issues, mostly patients can have renal derangements also. So heart failure with preserved EF, rarely it will have, because most of these patients are hypertensive. So hypotension is not something we associate in this group most of the time. Most of the time they are well tolerant to the doses, but sometimes the challenges mostly which we have faced clinically is the renal derangement in these patients, which we have to be very careful of. And we have to be more stringent in the monitoring of the renal function test in maybe HFpEF patients and go accordingly. So again, contraindications will range less than 10% for me. So hyperkalemia, as we manage with any other disease entity, the treatment options for hyperkalemia will always be there, but we should look at adding a minimal dose. Patients who are prone to developing hyperkalemia, we can add a minimum dose of a loop diuretic to them. So that is one of the things. The dose of the mineralocorticoid receptor antagonist can be decreased or withheld, and concomitant use of any other drugs which are nephrotoxic can be had a look, and other management points remain same. So low potassium diet is also one thing we should always keep in mind. Other are, we know that these are the treatment options for hyperkalemia.